There's emerging evidence that ChatGPT and similar AI systems are changing the sequence of healthcare seeking behavior, with many people now consulting AI before, or instead of, making medical appointments. This shift has both potentially beneficial and potentially harmful implications that we need to examine carefully. The pattern is understandable from a patient perspective. You wake up with concerning symptoms. Your first instinct used to be calling your doctor's office or searching Google. Now, it's opening ChatGPT and describing what you're experiencing. The AI provides immediate responses that might reassure you, alarm you, suggest self-care measures, or recommend seeking medical attention. Based on this interaction, you then decide whether to pursue professional medical care. This creates an initial filtering mechanism that could theoretically improve healthcare system efficiency. If AI can reliably identify truly minor issues that don't require professional attention and reassure people appropriately, it could reduce unnecessary appointments for things like common colds, minor skin irritations, or benign symptoms that don't need medical evaluation. This would free up appointment capacity for people with more serious needs and reduce healthcare costs. For people who would never seek medical care for minor symptoms anyway, AI consultation might not change behavior, but could provide useful information and reassurance. For people who would rush to the emergency room for every concerning symptom, AI might provide appropriate triage that directs them to less urgent care settings when appropriate. However, the risks of AI as a first stop are substantial and potentially life-threatening. The most obvious danger is delayed care for serious conditions. If someone experiencing early symptoms of stroke, heart attack, cancer, or other serious diseases consults AI first and receives reassurance that their symptoms are likely benign, they might delay seeking care during the critical window when treatment is most effective. Stroke treatment works best in the first few hours. Some cancers are curable when caught early but fatal when advanced. These delays could literally cost lives. AI cannot adequately assess symptom severity without physical examination and cannot recognize subtle patterns that might indicate serious disease. A person might describe their symptoms in ways that sound benign when the clinical reality is concerning. Conversely, someone might be terrified by relatively minor symptoms, and AI reassurance might appropriately reduce their anxiety and prevent unnecessary emergency care. The challenge is that AI currently cannot make these distinctions reliably enough to trust it with high-stakes triage decisions. The error rate might seem low in percentage terms, but in absolute numbers across millions of users, even a small error rate means thousands of people receiving dangerously wrong guidance about whether their symptoms require urgent attention. Design interventions could mitigate some risks. AI systems used for health questions should include prominent safety warnings that emphasize certain symptom categories always require immediate medical evaluation: chest pain, difficulty breathing, sudden severe headache, weakness or numbness on one side of the body, altered consciousness, severe abdominal pain, major injuries, and other red flag presentations. These warnings should appear regardless of what the user describes to ensure critical safety information is never omitted. Nudging users toward appropriate levels of care could be built into AI responses. Instead of offering binary, "see a doctor," or "this is fine" advice, AI could present more nuanced guidance. This symptom pattern could have several causes ranging from minor to serious. Given the information you've provided, scheduling an appointment with your primary care doctor within the next few days would be appropriate. However, if you experience specific warning symptoms, seek immediate emergency care. Graduated urgency scales could help users understand appropriate timelines. This requires emergency evaluation now. This needs medical attention within 24 hours. This should be evaluated within a week, or this can likely be managed with self-care and monitoring. This framework helps users convert AI information into appropriate action without oversimplifying into safe versus dangerous. Clinician adaptation to this new reality is important. Healthcare providers should ask patients during intake whether they consulted AI or other sources before seeking care and what information they received. This helps physicians understand the patient's decision-making path, correct misinformation, and address any AI-generated concerns that might be affecting the patient's understanding of their condition. Intake forms could include questions about pre-visit AI consultation to systematically capture this information. The deeper question is whether having AI as a first stop in healthcare seeking improves or worsens overall health outcomes at a population level. We don't yet have robust data to answer this question. To evaluate it properly would require large-scale studies tracking health outcomes for populations with and without AI consultation as a first healthcare step, controlling for numerous confounding variables. Until we have this evidence, claims about whether AI first-stop behavior is beneficial or harmful remain largely speculative. What seems clear is that AI as a first stop is here to stay regardless of whether healthcare systems and policymakers embrace it or resist it. The appropriate response is designing AI systems with adequate safety features, educating users about limitations and appropriate use, training healthcare providers to work with patients who've consulted AI, and conducting research to understand the actual impacts on health outcomes and healthcare utilization.